Hey there, and welcome to this explainer. If you're studying pharmacology or, just genuinely fascinated by microbiology, you already know that facing down an infection can feel a whole lot like preparing for battle. So today, we're going to take some incredibly detailed, complex pharmacology notes and turn them into a strategic, totally approachable study guide on how to treat bacteria. We're going to map out the entire antibiotic arsenal. All right, let's dive right in.
Let's start with a really fascinating foundational premise from our source material. What actually is an antibiotic? Well, according to the notes, an antibiotic is essentially a weapon derived from the bacteria themselves. We literally take their own substances, improve them in a laboratory, and then deploy them right back against them. It's biological warfare at its most ironic, right? But it forms the entire basis of our medical arsenal.
So, what are the rules of engagement here? Well, they're clearly defined right from the jump. Penicillins are generally deployed for gram-positive bacteria. Aminoglycosides are your go-to for gram-negative bacteria, and tetracyclines are reserved for the atypical bacteria. Now, sure, this is a broad overview, but it sets the stage perfectly for the specific tactics we really need to learn.
To master this topic, we're going to break our arsenal down into specific tactical targets. 1. Breaking the cell membrane. 2. Halting protein synthesis. 3. Stopping DNA replication. 4. The cost of treatment. And 5. Clinical order of preference.
Section 1. Breaking the cell membrane. Frontline defenses.
If a bacterium is a fortress, these drugs are literally our battering rams. And it's amazing to see how we've engineered these weapons over time. We start with natural penicillins, like penicillin G. These are great for gram-positive bacteria and spirochetes. But, bacteria adapt, so we had to develop semi-synthetic, broad-spectrum penicillins, like amoxicillin, to hit some gram-negative bacilli too. Then we run into bacteria like Staph aureus that actually produce beta-lactamase just to destroy our drugs. Our response to that? Anti-staph penicillins, like methicillin. Though, as the text carefully points out, if you are dealing with a resistant strain like MRSA, which is a super common hospital infection, you have to skip methicillin and go straight to vancomycin. Finally, we have the absolute heavy hitters, anti-pseudomonal penicillins like piperacillin, which target all gram-negative bacilli.
What's really wild here is the exact terminology the source notes use for drugs like piperacillin and fourth-generation cephalosporins like cefepime. They're literally labeled as atom bombs. I mean, wow. These are definitely not for your standard ear infection. These are strictly reserved for life-threatening infections where you absolutely must obliterate the bacterial threat before it kills the patient.
Let's talk about cephalosporins and see how this defensive strategy builds. It is so interesting how the cephalosporin generations systematically shift their target spectrum over time. First-generation drugs like cephridine are heavily focused on gram-positive bacteria. But as you move to the second and third generations, like ceftriaxone, the focus dramatically shifts away from gram-positive and heavily towards gram-negative. By the time you reach that fourth-generation atom bomb cefepime, it attacks everything, gram-positive and gram-negative. And the absolute latest, the fifth-generation ceftaroline, is our specialized countermeasure specifically for those highly resistant MRSA and VRSA strains.
Section 2. Halting protein synthesis, sabotaging the factories. Okay, so if we can't break the outer walls, or if we just need a completely different approach, our next tactical option is to bypass those walls and sabotage the bacteria's internal factories, the ribosomes. Bacteria absolutely rely on ribosomes to synthesize the proteins they need to survive. We can divide our protein synthesis inhibitors into two distinct strike forces based on the specific ribosomal subunit they attack. On one side, we have the 30S inhibitors. That includes your aminoglycosides and tetracyclines. On the other side, we have the 50S inhibitors, like chloramphenicol, erythromycin, and clindamycin.
Now, pharmacology requires a ton of memorization, so the essential trick here is finding ways to make the data actually stick. To easily memorize the 50S inhibitors, the text provides a pretty brilliant mnemonic, ATCELL. If you can remember ATCELL, you can instantly recall drugs like azithromycin, tetracycline— wait, actually, scratch that. Tetracycline is a 30S inhibitor. Let's stick strictly to the 50S ones mentioned for the C and E. Right, chloramphenicol, clindamycin, erythromycin, and lincomycin. It's an incredible mental shortcut for your exams.
When we drill down into these specific targets, tetracycline, or 30S inhibitor, is key for some gram-positive, some gram-negative, and crucially, atypical bacteria. Meanwhile, looking at the 50S inhibitors, macrolides like erythromycin offer really broad coverage across gram-positive, some gram-negative, and all atypicals. Importantly, they are explicitly labeled as the safest because they rarely cause more than mild hepatitis.
Section 3.
stopping DNA replication, halting reproduction.
Our final major mechanism of action is halting bacterial reproduction entirely. I mean, if a bacterium can't replicate its DNA, the infection simply cannot spread. The data maps out two main pathways to shut down DNA synthesis. The first is targeting folic acid. Drugs like cotrimoxazole combine sulfonamide and trimethoprim to do exactly this. But there is a massive caveat here. Are you ready for this? 90% of bacteria are now completely resistant to folic acid inhibitors. That's huge. The second pathway is inhibiting DNA gyrase using quinolones like ciprofloxacin. Now, these are highly effective against gram-negative bacteria, but they come with a heavy cost. They are neurotoxic and can actually induce seizures and fits, which naturally brings us to a crucial part of our strategy.
Section 4. The cost of treatment. Navigating the side effects.
The reality is, every single weapon in this arsenal has the potential for collateral damage, so now we've got to examine the friendly fire, or the adverse toxic effects. The notes clearly categorize these into 4 distinct buckets. First, anaphylactic reactions. These can range from simple skin rashes to life-threatening shock, which is exactly why a test dose is so often given. Second, irritative reactions, your incredibly common nausea, vomiting, and diarrhea. Third, superinfections. You see, when you wipe out the body's normal flora, opportunistic threats like Clostridium difficile, which causes pseudomembranous colitis, or oral and vaginal candidiasis can just take over. And finally, toxic effects, which are entirely unique to each specific antibiotic. Let's look at a few critical ones.
We have a massive, glaring red flag highlighted in the source material. It explicitly states, never use gentamicin with respiratory failure. But why? Well, because molecules of gentamicin, which is an aminoglycoside, can bind with acetylcholine receptors on the neuromuscular junction. This essentially creates a myasthenia-like syndrome, paralyzing the muscles. If a patient is already struggling to breathe, this toxic effect could easily be fatal. Another absolutely crucial, specific toxic effect detailed here is gray baby syndrome. This is a deeply tragic and fatal condition. If chloramphenicol is improperly given during pregnancy, it crosses the placenta. It then inhibits the fetal DGT enzyme, which prevents the conjugation of bilirubin. Because the baby cannot process this, the text states the baby will die within 48 hours after birth. It is a stark, sobering reminder of the immense responsibility that comes with prescribing these drugs.
When you put all this together, it really reinforces the sheer variety of toxicities that medical professionals must memorize to keep their patients safe. You have tetracycline causing bluish teeth staining and enamel disruption in children. You have quinolones inducing seizures, making them completely contraindicated for epilepsy. And you have severe nephrotoxicity and ototoxicity, meaning permanent hearing loss, associated with immunoglycosides.
Section 5. Clinical order of preference. Choosing the right weapon.
Okay, let's pull all this pharmacology data together into a practical, clinical framework. When a patient is actually sitting in front of you, which weapon do you choose first? Think of this next part as the ultimate cheat sheet for your studies. It maps exactly which drug to deploy first. For gram-positive bacteria, penicillin is your first-line defense. If they are allergic, your second line is erythromycin, a macrolide. For gram-negative, you're going to lead with a third-generation cephalosporin like ceftriaxone, keeping quinolones as your backup. For Wallace atypicals, you jump to macrolides or doxycycline. And for anaerobes, metronidazole is your primary strike, followed by clindamycin. It's a beautifully logical flowchart of escalating force.
But, of course, clinical preference changes drastically when dealing with special populations. We already saw the horror of gray baby syndrome. This is exactly why a specific highlighted section is dedicated solely to antibiotics that are actually safe to use during pregnancy. You can't just blindly follow the standard order of preference. You have to prioritize fetal safety above literally everything else.
So if you have a pregnant patient suffering from pneumonia, gastroenteritis, a UTI, or a skin infection, what are your options? The guidelines are very clear. You can safely deploy penicillins for gram-positive threats, cephalosporins for gram-negative threats, and macrolides for atypical bacteria without risking fetal harm. Sure, it greatly narrows your arsenal, but it absolutely ensures both mother and child survive the treatment safely. As we've seen throughout this explainer, our bacterial arsenal is incredibly vast, meticulously engineered, and deeply complex. We've traced the entire evolution from natural penicillins all the way to fifth-generation cephalosporins. But as bacterial resistance continues to grow, as 90% of bugs literally laugh off folic acid inhibitors, and as our absolute atom bombs are becoming standard issue for resistant infections like MRSA and VRSA, we really have to wonder, what will the future of treating bacteria actually look like? Will we find a brand new mechanism, or will the bacteria eventually outsmart our very best weapons?
Keep studying, keep questioning, and thank you so much for joining me on this deep dive into the antibiotic arsenal.